Good afternoon. This is Barbara Brandt, Director of the National Center for Interprofessional Practice and Education. Today's webinar in the series of the Accelerating Initiative, Interprofessional Community-Based Practice, Education and Practice Initiative is the University of Pittsburgh. And they will be speaking on promoting team-based interprofessional care for community-dwelling older adults with chronic disorders. This is an jointly accredited offering today, and so these are the lists of credits that can be awarded for today's participation. Disclosures, we do not have any conflicts of interest to disclose with this webinar today. So from the National Center, I will be turning this webinar over to Carla Dieter, who's been the coordinator of the Accelerating Initiative program and coordinator of the IPE, Nexus IPE programs for the National Center. Carla, I'm going to turn it over to you to introduce.
Thank you. I'd like to introduce our two presenters today, Lorraine Novosel, and she is one of the co-principal investigators. She's an assistant professor, coordinator of the Adult Gerontology Primary Care Nurse Practitioner Program from the Department of Health and Community Systems and the School of Nursing at the University of Pittsburgh, and Jennifer Lingler, who is also a co-principal investigator. She is professor, vice chair for research at the Department of Health and Community Systems, also at the School of Nursing. Our objectives for this webinar, as well as all the objectives for our previous webinars, are all the same. We're trying to show you how these teams really developed their Nexus IPE team, how the students and health professionals work together, key lessons learned, and then we're applying at least one learning system tool. And today we're talking about the critical events of IPE. We like to put this slide in every time in case there's new people on. I know that many of you have seen this over and over again. But we have the definition of interprofessional education from WHO, and then the call to action is that healthcare education and healthcare delivery must be simultaneously designed to be better integrated and more interprofessional while demonstrating outcomes. And this is what the National Center calls the Nexus. We want to thank our 4 private foundations, the John A. Hartford Foundation, Robert Wood Johnson Foundation, Josiah Macy Foundation, Junior Foundation, and the Gordon and Betty Moore Foundation. They were the 4 foundations that came together and provided support for the 16 sites across the nation. There are many aspects of the Accelerating Initiative program. It was a 2-year cohort. Sites got a $50,000 award, and plus significant technical assistance for 2 years, and they needed to match that $50,000. So I'm going to direct you for further details about the Accelerating Initiative to our website. We've been trying to sum up our presentations every time with our webinar in one slide. We've talked about the future being interprofessional. The key is really community practice. The focus is people, patients, families, and communities first. Not professionals and students, and I think that'll come loud and clear with this presentation today, as it has been coming clear in our previous ones. What's different, and here's the definition of the Nexus again. And then starting the University of Pittsburgh, they really started with a very strong relationship, which is a key factor of their success, and their outcomes were they're showing outcomes for both students, clients, and the health systems. And the key lessons from Pittsburgh are the importance of strong leadership and committed team members. Early successes can lead to expanded collaborations, and they also are teaching us that community partners thrive as full members of the team. And we've already mentioned that the critical events of IPE will be discussed. So I'm going to turn it over to Dr. Novosel and Dr. Lingler, and we'll let them take it away.
Thank you, Carla, for that introduction. Hi, everyone. I'm Lorraine Novosel, and first I want to thank you for taking time to join us today. Some of you may not, this may be your first webinar that you are watching for the Accelerating Initiative. So I just want to give you a very brief overview. The goal of the Accelerating Initiative was for health and other professional schools with a history of collaboration to work together with a community partner and the individuals and families that it serves to develop innovative, creative, and sustainable interprofessional clinical initiatives that accelerated existing interprofessional education. So to this end, the School of Nursing graduate programs, specifically our doctoral adult gerontology, primary care, and family nurse practitioner programs took the lead, and we partnered with academic colleagues and graduate students in our schools of pharmacy, health and rehabilitation sciences, and social work. And we also partnered with our Center of Interprofessional Practice and Education, which is housed within the University of Pittsburgh Health Policy Institute and co-directed by Dr. Susan Meyer, who many of you may know through your connections with the National Center. Through the university and the University of Pittsburgh Medical Center, or UPMC partnership, back in 2012, I believe, we were designated as a Nexus Innovations Incubator site. Our community partners then offered students diverse experiences, both across or in rural and urban settings and across community and primary care settings. Our first community partner, Staying at Home, is located and centered in the city of Pittsburgh. It is a program of the UPMC Senior Services. It is a care coordination service designed to help older adults with chronic health conditions receive the support needed to remain in their homes. The program provides clients residing in the Southwest Pennsylvania region with a nurse and social worker to promote health and facilitate their ability to maintain a safe, healthy, and independent life. A sister program, Living at Home, also run by UPMC Senior Services, is a geriatric care coordination program for ongoing in-home care for older adults. In the Living at Home program, experienced nurses and social workers develop a personalized care plan for each client and then recommend services to provide any needed care to help maintain their independence and functional ability in independent living. Our other community partner, Associates in Family Healthcare, is located in the rural community of Slickville, Pennsylvania, which is about 45 minutes outside of downtown Pittsburgh. This is a nurse practitioner-owned and managed health center that provides comprehensive primary care and health promotion services to individuals across the lifespan. The clinic primarily serves residents who live, work, and age in an environment with limited access to numerous social and economic opportunities and resources, which impacts their health, their functioning, and quality of life. The clinic provided our health profession students with a valuable, rich environment in which they could really develop an understanding of the social determinants of health. To share a little bit more about our team, these partnerships were, for the most part, what I would call established partnerships. However, our team as a whole was new. But the majority of us knew of or had connected with or collaborated with each other in various ways. And across our schools, we had established relationships with our community partners for student clinical rotations. So as a result of the critical event that we are going to discuss later in this presentation, we subsequently leveraged our relationship with our pharmacy colleagues and expanded our partnerships to include the Silver Scripts program, which is a community-based program led by the School of Pharmacy, where PharmD students go into the freestanding senior centers in the Pittsburgh community to help seniors manage their medications. I believe probably everyone listening to this is well aware that the age demographic of our country is changing and that our older adult population is rapidly growing. We also know that as a whole, they are a vulnerable population who have a lot of chronic conditions, with 2/3 reporting more than one chronic condition and nearly 40% with 4 or more chronic conditions. In Pennsylvania, the percentage of those 65 and older exceeds the national average. And then to bring it even closer to home, here in Allegheny County, roughly 17% of residents are over 65, which exceeds both our state level of 15% and the national level of 13%. Well, Jennifer, you may have it, but I don't. I don't have the most current data with me, but I've heard many times through the years that I've been here that in fact Allegheny County ranks second only to Miami-Dade County in Florida for the largest percentage of older adult residents. Not only do we have a lot of older adults residing in Allegheny County, but in each of the 8 counties surrounding us, the percentage also exceeds both the national and state averages. As a team, we really do promote and believe in aging in place. We want our older adults to live well, to remain independent as long as possible, and to enjoy a good quality of life in the process. Not only is this cost effective, but the research shows this is important to the majority of our older adults. So for us, it is very important to work to reduce the risk of disability. And at the same time, we want to ensure that our health profession students are very well prepared for interprofessional practice upon graduation and entry into professional practice. Next slide, please.
All right, this is Jennifer speaking now. Good afternoon, everyone, and thank you for teeing this up, Lorraine. I'm going to provide an overview of what our program at the University of Pittsburgh looks like. So this is the Interprofessional Education Exchange Program, otherwise known as IPEP. As Lorraine emphasized, our goal is to provide enhanced team-based interprofessional care for vulnerable community-dwelling older adults and to meet the core competencies for interprofessional collaborative practice. So how do we do that here at Pitt through the IPEP program? Well, in the true spirit of accelerating, this program builds on some existing programming at the University of Pittsburgh. So all graduate students participating in our program were required to first complete one or more of the university's established and existing interprofessional training programs and workshops. So these in-house campus-based programs where they meet and work with their peers and faculty to learn the foundations of interprofessional collaborative practice. So 3 examples of those: there's an interprofessional forum that's offered to all students of the health sciences in their first year in their program. There is a geriatric medicine course which spans all of the health science disciplines and social work. And then there's a geriatric mental health mini fellowship that we had been involved with, which was actually designed for individuals who may be practicing in primary care but are likely to encounter issues related to geriatric mental health. So we required that our students in the IPEP program had first completed one of these existing workshops. And each of these workshops is quite strong, brings students together, gets them interacting collaboratively, uses case-based approaches and simulation, but where we can see an opportunity for growth is that students were not having that experience of seeing an older adult in their home and problem solving with them as a team. So that's sort of where, if we were to identify where these programs might fall short in terms of meeting our vision for enhancing care for vulnerable community dwelling older adults, that's where we just weren't able to quite get students to that next step of having a clinical experience together. So the IP program uses exchange, as the title implies. So this is the idea that a student who is having a clinical practicum in one setting will be a host and have students from one or more other disciplines join them at their clinical practice site for anywhere from 1 to 3 visits. And it's described as observational in nature, but what they're doing is huddling as a team, and the visiting students from the visiting professions are providing consultation to the student who's hosting, and that's the student who's in a long-term placement at a given clinical site. So it's the host student's responsibility to then follow through with the goals that are set by the team as they consult together during the exchange. And then that student, of course, has the opportunity to visit their peers from other disciplines in their practice sites. So this provides an opportunity for them to observe one another, so they're learning about each other's roles, and again, they're actually having problem-solving experience together in a real-world clinical case. What we identified as far as some strengths of this exchange approach is the opportunity to overcome some of the main barriers to interprofessional education. These are barriers that we've experienced here at Pitt, and certainly ones that we hear echoed every time we get together with colleagues at other universities. So one of the first ones is scheduling and logistical differences, just in terms of how clinical placements are handled within various professional schools. So under this exchange model, the learners' schedules really only need to overlap anywhere from 1 to 3 days in order for an exchange to occur and for that team-based care to be implemented or at least initiated for the client. The second major barrier that we're trying to overcome with IPEEP is this idea that we don't have same discipline preceptors at various clinical placement sites. So this is especially programmatic for nurse practitioner students in the state of Pennsylvania. But we've been able to design this so that the students who are observing are guests and they are not required to have an on-site same discipline preceptor. And then the third barrier that we're trying to overcome is this, perhaps the most challenging one, is that we don't have enough exemplar models of interprofessional collaborative practice in which our students can train in clinical teams. So the IP teams are actually kind of simulated by the students forming their own team, and then we have opportunities for the students to access faculty from the guest students department, but using video conference and telecommunications. So we essentially, the students not only form, but also bring their own interprofessional team to the setting. Next slide. So what does this look like for the individuals participating? So on the client side, the interprofessional student teams are able to work with the older adult in goal setting, with the long-term goal being to reduce risk of disability and enhance quality of life, as Lorraine introduced in our objectives. In terms of a short-term goal, the interprofessional student teams were very focused on engaging the clients in client-centered approaches to determining shared priorities. So what does that mean? This is really the more short-term goal setting. So if the eye on the prize is aging in place, the interprofessional student teams were working on goal setting with clients. This is a approach that we learned from our occupational therapy colleague, Dr. Pam Toto, where a client in our programs are all community-based for individuals who are living in their homes. So our clients would identify a goal. Now, The interesting thing about that is because we really are client-centered and client-first, the goal would be framed and would remain framed in the client's language. So whereas someone from one of the health disciplines might identify a goal of having a person ambulate independently a certain amount of feet within a certain period of time, the client framed goal might be to walk to the lending library at the end of the street. And that's how the goal would remain framed. By having it be client-centered and client-first, we also avoid some of the discipline-specific jargon that we might get into and that could pose a barrier to effective teamwork within the student groups. So that's just an example there. Then once the goal is set, to develop and promote behavioral activation strategies to help the older adult achieve their goals. So again, this would be the huddle with the students from the various disciplines, and then the student that again is at the host site would be responsible for executing that plan, working with the client to achieve that goal over time. On the student side, the objectives were to improve students' attitudes and behaviors related to interprofessional collaborative practice, and their attitudes toward care of older adults in general. So not all of our students were in a geriatric specific area of concentration within their program to participate in IPEEP. And also, of course, we employed a variety of activities and this emphasis on the clinical exchange experience.
Thank you, Jennifer. I'd like to take a little bit of time now in the next few slides to talk a little bit about our outcomes and our successes so far. First, we aren't able, as of yet, to state that we have demonstrated outcomes related to improving access to care, better quality of care or reduced cost of care. However, we are making progress towards improving healthcare delivery for clients and connecting them to needed services. And we're seeing and hearing of a lot of satisfaction from the clients that our students are working with. They do seem to enjoy and actually, for the most part, welcome teams of students in their care. In fact, we've received a lot of comments from clients about how they feel honored in helping to then turn around and contribute to the learning and the education of the students, how they like giving back, and how satisfied they are with the interprofessional student teams that are working with them. And also, if perhaps even most importantly, we have found that they are actually okay and accepting of having student teams work with them. I'd like to say that of note, we generally try to really limit the number of students on any given team on any given day to 2 to 3 maximum at any one time, so that we don't place an undue burden on our older adults, as we certainly don't want to put them in a situation that could be overwhelming. And quite honestly, having more than one provider with them is a bit out of the norm for their usual healthcare or health encounters for many of them. In addition, staff members of our community partners have noted and reported on what they're calling social and emotional benefits to their older adult clients that they've observed through the intergenerational interaction that the older adults have with the students. So it's been a win-win, and it seems as though that all stakeholders across the board are seeing benefits. Next slide, please. From the academic partnership side, we're clearly seeing excitement build across the health science schools, and we've had several other disciplines ask about our program, and engage in discussions to see how other students and faculty could participate in the IPEEP program. At the beginning of our work, the adult gerontology and family NP programs were on board, along with graduate students and faculty in the School of Pharmacy, Social Work, and with Occupational Therapy, which is housed in the School of Health and Rehab Sciences. Very shortly after we started, the doctoral, psychiatric, mental health nurse practitioner faculty asked to have their students participate, and we welcomed them, and their key faculty, Dr. Hee-Young Lee, joined our team. Our colleague, Dr. Luke Barenbrock of the School of Pharmacy, later engaged with graduate audiology students and worked to enable them to join in the interprofessional exchange activities, which we feel really brought a new perspective to what we were doing, particularly to our nurse practitioner students, as audiology is not a discipline that we have historically interacted with or have had opportunities to interact with through their educational program. We've also been approached by the physician assistant program, but there are challenges right now that are limiting our ability to accommodate them and engage with them at this time. But certainly that we hope to be able to do that down the road. And I'm sure we would be asked, what about medicine? We have a prominent medical school right next door to us, and we've certainly had discussions with them. But at the present time, very simply, our academic calendars and schedules do not align in a way that would make this possible to engage them. Next slide. The leadership of our community partners, I have to say, has been very supportive from the beginning. Resistance was never an issue from the community side. In fact, our partnering agencies really seem to take pride in their role as educators and as university partners, and they often speak of both a professional and a personal dedication to preparing the future geriatric workforce. Our local professional geriatrics community is rather tight-knit and collegial. Here, almost everyone, I believe, knows of or is connected to or knows of somebody who knows of somebody else. And so collaboration is common. As our students have engaged in this program, or as they engage in the program, they are then introduced to and invited into this network, which in turn gives them access to an expanded cadre of mentors, other practitioners, both by their student peers, so soon-to-be practitioners, and practitioners that are currently in practice, and with potential future colleagues. So in essence, they begin to build their own professional, collaborative, and consultant network while they are still in the student role. And on a side, it clearly is certainly our hope that these students then can inspire others to consider working with older adults in the future. Over time, our relationships certainly have evolved and strengthened, and we embraced other opportunities to engage other partnerships, for example, with the Silver Scripts program, which we talked about earlier. What was clear from the beginning, and honestly somewhat different from other academic community partnerships, is that, in where we, and I'm talking about myself and colleagues as faculty, oftentimes scurry about to secure appropriate clinical learning opportunities for students for the purpose of securing appropriate clinical learning opportunities for students to meet academic requirements. What was different here is that we came together this time for a different purpose, with a different goal in mind, and that was, what can we do together to help our older adults, first and foremost, which was something different from what seems to be the norm for academic practice partnerships. For me personally, I do believe this was the first time that I actually intentionally pursued a clinical partnership from this lens. And to be very honest, while it was a new approach, it was actually refreshing to go about something in healthcare that actually returned our focus back on the client or the patient first. While we say that we deliver patient-centric care, I think we can all probably agree that what we actually see in day-to-day practice today still doesn't always quite live up to how it should be or could be. Next slide, please. On the education and student gain side, this is the area in which we have seen our most significant impact. Through the exchange program, students have exposure to team-based care with an older adult population, again, many of whom have limited access to many social and economic opportunities and resources. We have demonstrated improved or more positive attitudes and behaviors related to interprofessional education and practice towards the older adult population in general, and we've seen and with our students have reported high levels of satisfaction with the interprofessional education exchange experience. We've also observed our students have a greater awareness of the impact of social determinants on health through engaging with clients and patients in both our community partners, both in the urban and in the rural settings. I don't think we've mentioned this yet, but participation in the IP program was voluntary for students. Our target expectation was to have 20% of students in each discipline participate. We're very happy to say that we exceeded our goal and have had at least 50% participation in all founding disciplines, with the exception of one, which was our OT within the OT area, which actually had a 40% participation rate. So that is still extremely good, and we are very happy with that. On average, for the students who have participated in the exchange program so far, they have participated in an average of 5.3 encounters of the interprofessional student teams and clients. And then specifically looking at our outcome measures, we assessed at interprofessional attitudes using the IPASS. Students completed this both at baseline and then at the end of the term in which they participated in the exchange experiences. And as you are probably well aware, there are 5 subscales of the IPASS. Student ratings on 4 of the 5 subscales increased from baseline to the post-assessment, although the data at this point in time do not meet the level of statistical significance. On the 5th subscale, which was the patient-centeredness subscale, there was no change between baseline and follow-up, which actually I think is a reflection of how our educational programs are today, very much stressing the importance of delivering patient-centered care. We evaluated student competency, attainment, and their behaviors using the 20-item ICAS, which students completed at the end of their participation in the exchange activities. Our data revealed increases in student ratings across the board on all 20 items of the ICAS. Significant increases, however, when we were compared before to after the exchange responses were noted on 16 of those 20 items. Briefly, I'd like to talk about the geriatric attitude scale, which is very important for all of our team members, since this is an intervention that is a program that focuses on the older adults. We utilized the 14-item GAS developed by Ruben, and we slightly adapted the wording to bring it a little bit more up to date with the current time. Very briefly, the GAS is measured on a 5-point Likert scale, with 1 to 2 denoting a negative attitude, 3 being neutral, and 4 to 5 denoting a positive attitude. All items then are summed and divided by 14 to get a final score. For our students, the mean score at baseline was 3.9 and then 4.0 at the completion of the program. So really this would fall at the very high end of neutral attitudes towards older adults, right tipping over into the positive stage. Certainly, our findings were not statistically significant, and our findings are similar to many published studies of various health science students' attitudes towards older adults. It does remain a challenge, an ongoing challenge across disciplines and in healthcare across the board. And then finally, we were interested in hearing of our student satisfaction with the exchange program, and we measured this on a 5-point Likert scale. And at the end of the program, or at the end of the exchange programs, the average student satisfaction score rating was 4.5, indicating that they were very satisfied to very highly satisfied with the exchange experiences. Next slide.
I'm going to add an anecdote and go off script.
Absolutely. Please do, Jennifer.
So I recently had the opportunity to review some materials. Dr. Novosel has been nominated for a teaching award here at the school, but there were multiple letters from students, and within those letters was reference to this program in particular.
Oh my.
And yeah, expressions of gratitude for getting them this exposure. So we'll have
nice to hear. Thank you.
add that to the database. So key lessons. So Dr. Novosel talked about lessons in terms of learner outcomes. Obviously, we have these ambitious goals related to our client outcomes with respect to aging in place, but key lessons for us as educators in the nexus were that strong relationships with community partners paid dividends over time, and that addressing a critical community need brings potential long-term benefits. So if you're doing something that's of value, you're likely to have this ongoing and authentically engaged relationship with the practice provider. And third, that understanding the practice setting is just absolutely critical for interprofessional curriculum development. So a couple key takeaways to share with respect to these points. First, we found that true interprofessional education relies strongly on leadership and committed team members. We have to be all in as a team, and this is both from the academic side and the community partner side. We were fortunate that each of our team members came with a strong commitment and passion for the initiative. I think this was one of the major drivers of our success, and both Lorraine and I have commented on numerous occasions that this was just one of the best teams that we've ever worked with in all of our academic years. There was just a clicking that occurred from day one. It says a lot about individual personalities, but also just a great group of people. So for sure we had moments and continue to have moments of frustration and challenges, but it seemed as though there was always someone on the team who was ready to rally the others and keep us engaged. Someone always stepped up to that plate of getting everyone back on task in a positive manner. And as I said, some members had worked together before. Those who had previous experience working on interprofessional teams or with an interprofessional education did provide this additional layer of leadership by sharing their experiences with the rest of the team. So together we decided to collectively join our resources and work toward a common goal and address the needs of a vulnerable population. Our community partners are trusted colleagues. We don't feel a power differential there. The learning is bidirectional and mutual. We realize that the academic side doesn't know everything and is not the keeper of all knowledge. I do feel comfortable saying that our partners feel the same way. Our community partners were just equal members of the team with equal input, equal say, equal vote in all matters, and that made collaboration easy. I think this really was kind of brought home for us during our site visit. By that point in our initiative, it just felt like business as usual. So it was very gratifying to have a sort of third-party perspective on this and remind us of how fortunate we were that the team was functioning so well. So it really is important to talk a bit about the importance of truly understanding the practice setting, that third bullet there. It can take some time to do that as you truly want to do a 360-degree scan. It's only through relationships, though, that you can branch out to more and more members of the partnering agency to understand the nuances of a particular practice setting, how it truly functions, who the key people are, how best to approach and interact with them, what's most important to the agency and to its clients. So again, having already established relationships with our partners provided us with this strong foundation from which we were able to build.
Okay, Sean Diego, you want to back up just a minute before we get into this part? I want to bring home just a couple of things that both Jennifer and Lorraine have emphasized, and with the Accelerating Initiative and the technical assistance that the teams received, the whole point really of our program and our coaching and our and the gelling that we were working with each of the teams was really, and the tools that we were using was to have these teams create a new and different partnerships. And they brought that point home very well, and putting the patients, clients, families, community first. It was very obvious, and Lorraine made that point, and I just want to bring that home again. And part of that is really developing that compelling vision together. And this isn't just a vision of the education side or a vision of the practice side. This was their compelling vision. And this whole concept of Jennifer and Lorraine saying that they were just all in as a team wasn't by accident. They really worked at this, and I do believe that this is likely the reason that Lorraine and Jennifer are also finding that this is the most gratifying team they've ever been on. So that's my comment. Barbara, do you have anything to add about that?
No, I think you did a great job.
Okay, we'll move on. So I do want to talk just real briefly. We've talked before about the IOM IPLC model being the conceptual framework for really measuring the impact of IPE, and that the National Center is working with that. Sean, you want to go to the next slide? We have expanded this and looked at what we're calling an IPE core data set. And we have different measures that match up with each one of these areas in the IOM IPLC model. And one of the areas that you'll notice in the green is the enabling and interfering factors. And how we're measuring this is the critical events of IPE. So you can go to the next slide. That's one of the tools that we utilize. The critical events of IPE is one of the tools we utilize throughout our work with the Accelerating Initiative teams. Next slide. So this is, we have been collecting data actually in the Nexus Innovation Network that many sites across the nation have been part of, including Pittsburgh, since 2014. And we really focused in on the experience with the 16 sites in the Accelerating Initiative because it really magnified what was going on when we were dealing with working with 16 sites all at once. We came up with, we evaluated and looked for themes and variables of critical events of IPE, and you can see them listed here. They can be anywhere from staff changes to a change in program strategy, unforeseen external forces, external partner change, internal partner change, difficulty obtaining program data, money resourcing problems, all of those kinds of things. And we also found that, many times people think that this is only a negative outcome when something happens. We found that really they can be positive, negative, or neutral impact on IPE and outcomes. So what we have developed, next slide. We have now the National Center IPE Information Exchange, and it's designed with the core data set. And this brings together a network of community that learns together to improve practice and advance our field. And data collection and sharing is one aspect of that work together. But this, one of the things that we are able to do is actually provide an avenue for sites to record their critical events and answer some simple questions, and then to track those critical events. So we know that that there's many different ways that things are resolved. And so based upon qualitative analysis of over 100 reports, those 7 broad themes emerged. And we know then that initially that we were calling these critical incidents, and they had negative connotations within healthcare, obviously. And so we changed our title to critical events instead of critical incidents. So we have the opportunity now for those that are members of the Nexus Innovation Network and the National Center IPE Information Exchange inside our core data set to actually capture those and those critical events and track them, and then compare them with others who are also submitting their critical events, and see whether they have a positive, a negative, or a neutral impact, and how they compare nationally with others who are experiencing critical events. Many times you feel like you're the only one, and nobody else is experiencing what you are, and you feel like you're all alone. And in this aspect, you can have a real-time report that would be able to help you identify for your leadership of what's going on with the program. It gives another layer of data to show them, as well as grants, grant opportunities, or reporting back to your grantors. So there's many aspects and very positive things about this tool that we're very excited about. Barbara, do you want to add anything to that?
No, I think you've done a very good job talking about what Pitt is now going to talk about. So
I'm going to turn it over.
So we have for the last 5 years collected these sites, these incidents, and have developed themes that evaluator qualitatively analyze them. And so next, Pitt is going to talk about how they use this tool for their own program development. So Lorraine, team.
And Sean, you can go to the next slide.
Thank you. So yeah, it's Jen. Okay, so yeah, we talked about how things were just going along swimmingly at Pitt. One of our key community-based care partners was a program at the University of Pittsburgh Medical Center called Staying at Home. So this was a home-based case management program that really was so central to everything that we were doing, because it was the original interprofessional collaborative practice and education site for us. Social work students had started having occupational therapy students come right around the time that we were developing this initiative. So we really built from that and modeled so much of what we did at the other sites after how things were working at the Staying at Home program. So, the example on the slide with the critical event tool on the previous slide was of a change in a staff member. So this wasn't just a change in a staff member, but we were actually notified in the spring of 2018 that the UPMC was closing the stay-at-home program by the end of 2018. So they notified us in spring that by the end of the year, the program would be closed. So this is a decision that would impact over 600 staying-at-home clients in the greater Pittsburgh area, 30 staying-at-home employees, and a decision that would also eliminate clinical opportunities for these key social work and occupational therapy students who were all teed up to host students from the other disciplines as part of our clinical exchange program. So collectively, the UPMC Staying at Home, and there's a sister program, Living at Home. These community partner sites were where we were planning to explore the client outcomes of the IP student teams, because we had such tremendous buy-in from these programs that they were willing to work with us to collect the client side data on reducing disability in these community dwelling older adults, examining the impact on quality of life, and also assessing goal attainment. I talked about the goal setting intervention that was so paramount to this teamwork. So this was a blow, to say the least. So immediately after announcing the pending closure of the Staying at Home program in the spring of 2018, the Staying at Home employees started seeking other employment opportunities. This is, what we were hearing about through our relationships. It's very quickly limited opportunities for student experiences, let alone exchange experiences, but for students' experiences at all due to staffing issues. So in May of 2018, we were notified that despite the earlier announcement and plan to close the program by the end of 2018, they were actually going to be closing sooner. So it was no longer, so the news went from bad to worse. We were first told it would be by the end of the calendar year 2018. Well, then we learned in May that by the end of summer, they were going to be closing. So this event really did represent a fork in the road for us. Losing this absolutely critical community partner significantly impacted our ability to access the community dwelling older adults that we were, again, had these plans in place to collect the outcome data on, and also would require us not only to adjust our timeline, but our benchmark goals for the project and to explore additional opportunities for community partnerships. So initially, for sure, without a doubt, we perceived this as a very bad thing. We already perceived ourselves to be behind on our timeline due to some earlier process delays. And now here we were losing access to a significant part of our client population. And we really wanted to get in there to bring the IP student teams in, teach them about goal setting so they could begin to work with the older adults to reduce disability. We wanted to get in, start collecting that data. So as a team, we were looking at this and saying, now what? We'd gone through, an IRB approval, all of this work. So, but at the same time, two of our key faculty members from our team, Ray Engel from social work and Pam Toto from occupational therapy, they were faced with the more pressing and urgent question of what do they do for field placements for their students. So then at this point, the team engaged in problem solving and thinking. So what if, what's going to happen? What if the new field placements for these students aren't suitable for an exchange program? What if they won't accept additional students? You certainly can't have an exchange program without willing partners. So what did our team learn from this event? Well, we mentioned on the earlier slide the importance of that strong relationship with the clinical partner, in this case, our community-based care partner. So within a very short period of time, we were actually reassured by the director of both the Living at Home and Staying at Home programs, Missy Sovak, that she wasn't going anywhere. Her position would remain in place, and that we still had the full support of her leadership, and that we would find a way to leverage connections with the remaining Living at Home program. So it certainly took a bit of time for everything to settle down and balance out. There were a lot of changes, relocation of offices, redistribution of work effort for the community partner staff, but sure enough, Missy did come through for us. And again, we attribute this to the strength of our relationship with our partner and their commitment to working together toward our common goal. If Missy had had any reservations about this partnership, this would have been the perfect opportunity for her to bow out. And certainly with everything that she had going on at her site, to make the decision to keep her commitment to us and find a way forward is just really tremendous, just above and beyond. And I think, again, it comes back to the notion that, yes, she is certainly a champion of students and of interprofessional education, but first and foremost, she's a champion of the care of older adults. And so if she saw a way forward with the companion program Living at Home, she made sure to see that through to fruition. So we also did quite a bit of brainstorming on our part, though. We certainly, as a team on the academic side, weren't about to just leave the problem up to the clinical site to solve. So we started working for securing additional sites. And so to that end, we were able to leverage Dr. Luke Berenbrock. He's a faculty member in the School of Pharmacy. He had a relationship with the city senior centers. They have a program called Silver Scripts, and we were able to develop a plan for using Silver Scripts as a program, as another site for our students to engage in those hands-on IPE experiences with older adults. So initially, pharmacy was to guest, but now pharmacy had the opportunity to host in our exchange program. So that was our first critical event. Lorraine's going to introduce critical event number 2.
Carla, I realize we're tight on time. Would you like me just to go through this relatively quickly, or not do this?
You can. I think that maybe what we should do is Jennifer did a wonderful job in explaining, really what happens with critical events. We can see that you've had two more things that have gone on that have happened, and they fall very well into the different categories. And Jennifer's, the one that she just explained, was an external partner change, and there's lots of other little nuances that you can add to that. I think we might be better to open it up for some Q&A and allow people to have the opportunity to ask you some questions. So I'd like to open it up a little bit here. And then if we have time, we can talk a little bit more about that second one, which was another major event. But it does emphasize that this happens to everybody. Things can be going along wonderfully, and then things happen. So can we open up for question and answers? Does anybody have a question? You can either put it in the chat box or into the question box, and we can field some of those. And maybe while we're seeing if anybody has any questions, you can briefly talk about those last 2 critical events, Lorraine. I'll monitor for questions.
Sure. Just very briefly, we had a lot of success, but clearly challenges and bumps in the road. The critical event number 2 that I was briefly going to talk about, second critical event, was the retirement of one individual who held multiple positions within the School of Nursing. And of her many roles, she was the FNP program coordinator and also director of our overall DNP program. We unofficially knew about the impending retirement for about a year, but the official announcement didn't come out until I think about 60 days prior to her actual retirement date. And the selection of and the naming of a new FNP coordinator and a new DNP coordinator, wasn't made until that time. So, we really, I think, compared to the closure of staying at home, which I have to admit was like a negative, we had a negative initial reaction. Knowing about this impending retirement, I think for all of us collectively, it took on more of a neutral tone, and we stayed in that framework for some time, had that viewpoint, because we knew that, this could either be good, bad, or, really bad for us, but we remained positive. So this fork in the road was actually more of a neutral fork in the road. We just needed to sit tight and see how, who the new director was going to be, who the new FNP coordinator was going to be, and would we then be in a situation to establish new relationships or to build on existing relationships or even to capitalize on established relationships. And we were lucky because they both individuals who are named, we did have establish relationships with them, so we are working together. And just very quickly, finally, we are now in the process of what I'm referring to as a positive fork in the road. We are about to experience leadership change at yet another level. And we have a new Senior Vice Chancellor of the Health Sciences coming in July. And from what I've heard from across others, from colleagues across the university and from those who were involved in the search committee process, he is very much interested in advancing interprofessional education across the schools of the health sciences. And we really look forward to learning of his priorities and working with him. So as of right now, we're viewing that as a positive fork in the road, and looking forward to him joining us on campus.
Thank you, Lorraine and Jennifer. You've done a marvelous job. I did see the one question of whether the slides are going to be available. We record every session, and the session is posted at the same site where you signed up. So it will be available on the website. It usually takes about a week to get that up. And anything else to tie things together? Barbara, do you want to have any closing remarks?
No, so I thank everyone who's on this webinar. I can see the names. And Lorraine and Jennifer, I truly thank you for your work, and especially your willingness to share the challenges of IPE implementation as well as the successes, because it's very normal, and that's how we're going to all learn. So I want to thank you for sharing with us and frankly participating in the Accelerating Initiative. And we all look forward to everyone continuing to learn together. So I'm going to close the webinar, and indeed this webinar will be archived with the voiceover, with the slides, as are all of our webinars. So again, I'll close this, and I want to thank all of you for participating. Thank you.
Thank you.
Thanks.
Bye.